Management of holoprosencephaly requires a multidisciplinary approach addressing the complex medical needs while supporting families through difficult decisions. Understanding the prognosis helps guide appropriate care planning and resource allocation. Acute management focuses on addressing life-threatening complications and providing supportive care. Ventriculoperitoneal shunt placement for hydrocephalus provides symptom relief by reducing intracranial pressure, though it doesn't improve neurological function. Endocrine evaluation and replacement therapy become essential for managing the common hormonal deficiencies. Diabetes insipidus treatment with desmopressin helps maintain fluid balance, while thyroid and adrenal hormone replacement address other deficiencies. Seizure management requires careful medication selection and monitoring, as many patients develop intractable epilepsy. Multiple anti-epileptic drugs may be necessary, and some seizures remain refractory to treatment despite aggressive therapy. Feeding support often requires tube feeding due to poor coordination of sucking and swallowing reflexes. Gastrostomy tube placement may become necessary for long-term nutritional support in severely affected infants. Prognosis varies significantly by severity, with allobar forms carrying the worst outlook. Many infants with allobar holoprosencephaly do not survive the first year of life due to the severity of brain malformation and associated complications. Semi-lobar and lobar forms may allow survival to early adulthood, though severe developmental disabilities remain universal. These patients require lifelong supportive care and typically achieve minimal developmental milestones. Quality of life considerations become central to care planning discussions. Families must weigh the burdens of intensive medical interventions against realistic expectations for meaningful neurological improvement. Family counseling requires exceptional sensitivity and ongoing support. Genetic counseling and testing help identify hereditary causes and guide family planning decisions for future pregnancies. Multidisciplinary care coordination involves neurology, endocrinology, genetics, and other specialists working together to address the complex medical needs. Social work support helps families navigate the healthcare system and access community resources. The focus shifts toward comfort care and family support when aggressive interventions offer little benefit. Palliative care principles help maintain dignity while addressing symptoms and supporting the family through this devastating diagnosis. Understanding microcephaly's precise definition and classification forms the foundation for effective NICU assessment and family counseling. Microcephaly is clinically defined as an occipitofrontal circumference greater than 2 standard deviations below the mean for age and gender. This threshold represents a critical decision point because accurate measurement directly impacts diagnosis, prognosis, and intervention planning. The distinction between primary and secondary microcephaly has profound clinical implications. Primary microcephaly is evident at birth, indicating intrauterine growth restriction of brain tissue, while secondary microcephaly presents with normal head circumference at birth but develops over time due to acquired insults or progressive conditions. This temporal pattern helps narrow differential diagnosis and guides evaluation priorities. Severe microcephaly, defined as greater than 3 standard deviations below the mean, carries particularly concerning prognostic significance. Research demonstrates that approximately 80% of children with severe microcephaly develop developmental disabilities, making this classification crucial for family counseling and care planning. Von der Hagen's landmark retrospective study of 680 children with microcephaly provides essential epidemiological context. Around 60% of cases have an identifiable etiology, with genetic causes accounting for roughly half of these identifiable cases. However, 40% of microcephaly cases remain without a clear cause despite thorough evaluation, highlighting the complexity of this condition. These statistics help set realistic expectations for diagnostic workups and emphasize the strong predictive value of microcephaly for neurodevelopmental outcomes in clinical practice. Systematic understanding of microcephaly etiologies guides targeted diagnostic approaches and influences prognosis counseling. Contemporary research reveals that genetic causes account for approximately 50% of identifiable cases, representing a significant shift in our understanding of this condition's underlying mechanisms. The genetic spectrum encompasses chromosomal aneuploidies, including various trisomies and deletions, de novo copy number variants that occur spontaneously, autosomal recessive primary microcephaly genes, including the MCPH gene family, and X-linked disorders with sex-specific inheritance patterns. These genetic mechanisms affect fundamental cellular processes, including cell cycle progression, DNA repair, and neuronal proliferation. Acquired causes represent the other major category, with torch infections being the most clinically significant. Cytomegalovirus emerges as the most common congenital infection, followed by toxoplasmosis, which uniquely can present with both microcephaly and hydrocephalus. Birth complications, hypoxic ischemic injury, maternal disease, teratogen exposure, infarction, and craniosynostosis complete the acquired spectrum. The recent emergence of Zika virus has added a new dimension to microcephaly evaluation. Maternal Zika infection during pregnancy targets neural progenitor cells directly, causing increased cell death, downregulated proliferation, and altered neurospheres production. This mechanism produces particularly severe microcephaly compared to other congenital viral infections, emphasizing the importance of maternal travel and exposure history in the diagnostic evaluation process. Torch infections represent critical acquired causes of microcephaly with distinct clinical patterns that guide diagnostic evaluation and management strategies. Understanding these patterns enables rapid recognition and appropriate intervention. Cytomegalovirus stands as the most common congenital infection, with an incidence of 6 to 7.5 per 1,000 live births. CMV produces characteristic periventricular calcifications visible on neuroimaging, along with sensorineural hearing loss affecting greater than 70% of symptomatic newborns. Importantly, 80% show hearing loss early, though it may be absent at birth and evolve over time, necessitating frequent audiological assessments throughout childhood. Chorioretinitis completes the classic CMV triad. Early ganciclovir treatment demonstrates remarkable efficacy, with 84% of recipients showing improved or maintained hearing compared to 59% of controls. Toxoplasmosis, caused by Toxoplasma gondii, presents unique clinical features including the capacity to cause both microcephaly and hydrocephalus simultaneously. The immune response and direct parasitic impact cause leptomeningeal and cerebral necrosis, leading to dystrophic calcifications in basal ganglia and periventricular regions. The classic triad includes intracranial calcifications, chorioretinitis, and either microcephaly or hydrocephalus. Treatment with pyrimethamine, sulfadiazine, and leucovorin for up to 1 year proves most effective when initiated prenatally. Other torch agents include syphilis, varicella zoster, and parvovirus B19. Rubella produces the classic constellation of cataracts, heart defects, and deafness, while herpes simplex typically manifests as encephalitis with characteristic skin lesions. Recognition of these distinct patterns enables targeted evaluation and optimal therapeutic intervention. Cortical malformations represent some of the most severe complications associated with microcephaly, fundamentally altering brain architecture and clinical outcomes. These malformations result from disrupted neuronal migration and cortical development, creating distinct patterns recognizable on neuroimaging with specific clinical implications. Lissencephaly, literally meaning smooth brain, demonstrates absent or minimal Chiari formation, creating a characteristic smooth cortical surface. This malformation results from neuronal migration defects affecting genes like LIS1, DCX, and tubulin genes, which control microtubular functioning and intracellular transport. The severity correlates with the extent of ageria versus pachygyria, with complete ageria representing the most severe form. Pachygyria presents as broad, thick gyri with shallow sulci, representing an intermediate form of lissencephaly. This pattern indicates partial success of neuronal migration with incomplete cortical folding. The rostrocaudal gradient often helps identify the underlying genetic cause, with different genes producing characteristic distribution patterns. Polymicrogyria demonstrates excessive small gyri formation occurring at the end of neuronal migration during cortical development. This malformation can result from congenital infections, like cytomegalovirus, vascular anomalies, genetic syndromes, including 22q11.2 deletion syndrome, or single gene mutations. The location and extent determine clinical presentation severity. Clinical features typically include seizures developing between 6 to 12 months of age, spastic quadriparesis affecting all extremities, severe developmental delays across all domains, and feeding difficulties requiring specialized support. The prognosis directly relates to malformation severity and associated brain abnormalities, with more extensive cortical involvement predicting poorer neurodevelopmental outcomes and greater care requirements throughout life. Macrocephaly, defined as an occipitofrontal circumference greater than 2 standard deviations above the mean, represents a critical diagnostic challenge requiring systematic evaluation to distinguish between 3 fundamental pathophysiologic categories. This classification directly impacts both diagnostic approach and therapeutic decision-making in the NICU. Hydrocephalus emerges as the most common cause of macrocephaly in neonates, resulting from impaired cerebrospinal fluid dynamics. Normal CSF production occurs at approximately 0.3 milliliters per minute, with the newborn maintaining a total volume of about 50 milliliters. When CSF absorption fails to match production rates, ventricular enlargement develops. In neonates with open sutures, this manifests as progressive macrocephaly with tense, bulging fontanelles and split sutures, while older children present with signs of increased intracranial pressure without necessarily developing macrocephaly. Megalencephaly involves actual brain tissue enlargement and rarely presents in neonates since it typically develops over time. When present, it associates with developmental delay and epilepsy. The causes divide into metabolic categories, including organic acidurias like glutaric aciduria, lysosomal storage diseases, and leukoencephalopathies, and anatomic categories involving pathogenic variants in genes affecting cell growth pathways, including PI3K/AKT/MTOR, ROS/MAPK, and SHH. Specific syndromes include megalencephaly, polymicrogyria, polydactyly hydrocephalus syndrome, and megalencephaly capillary malformation syndrome, with pathogenic variants identified in AKT3, PIK3R2, and PIK3CA genes. Benign familial macrocephaly represents the most favorable category, where large head circumferences run in families without associated developmental concerns. These cases typically show accelerated head growth with increased extraaxial fluid during the first year, likely due to imbalanced CSF production versus absorption by immature subarachnoid granulations. The prognosis depends entirely on the underlying cause, making accurate categorization essential for family counseling and clinical management. Agenesis of the corpus callosum affects 0.5 per 10,000 births in the general population, but increases dramatically to 600 per 10,000 in children with neurodevelopmental disabilities. This represents approximately 50% of all midline defects, making accurate recognition essential for proper evaluation and counseling. The corpus callosum normally functions as the brain's largest commissure, consisting of approximately 190 million axons that connect the cerebral hemispheres and facilitate interhemispheric communication. When absent, the destined callosal fibers redirect to form Probst bundles that run parallel to the lateral ventricles in an anterior to posterior direction rather than crossing the midline. These Probst bundles appear inconsistently, but when present, serve as useful distinguishing features on neuroimaging and may indicate better prognosis. Complete agenesis involves absence of the entire corpus callosum, while partial agenesis more commonly affects posterior portions, particularly the splenium. This pattern reflects normal development since callosal formation proceeds through a complex, multi-step process occurring between 10 to 20 weeks of gestation, involving midline patterning, cellular proliferation, migration, and axonal growth mediated by multiple gene networks. The malformation creates characteristic anatomic changes visible on imaging. Absent septum pellucidum reflects disrupted midline development since these structures form during the same developmental window. Colpocephaly develops as enlarged posterior lateral ventricles lose their normal architectural support from absent callosal fibers. The third ventricle appears high-riding due to absence of the overlying corpus callosum. Gural arrangement becomes radial with abnormal gyration of the medial hemispheric portions, eversion of cingulate gyri, and sulcation perpendicular to the hemispheric long axis. Environmental factors can cause agenesis, with ethanol exposure showing the strongest association, reported in 7% of children with fetal alcohol syndrome. Prenatal infections rarely cause isolated agenesis, but more commonly produce corpus callosum thinning with typical rostral to caudal patterns. The condition can result from prenatal infections, vascular accidents, and various teratogen effects, though genetic factors predominate in most cases. Corpus callosum agenesis represents a feature of hundreds of different disorders, with all modes of inheritance observed. Glass and colleagues' California population study demonstrated that Callosal anomalies associate with chromosomal abnormalities 17% of the time, most commonly aneuploidies involving chromosomes 13, 18, and 21. The condition also serves as a primary feature of several important genetic syndromes, including Mowat-Wilson syndrome, Aicardi syndrome, acrocallosal syndromes, L1CAM-related spastic paraplegia, and X-linked lissencephaly, with agenesis and ambiguous genitalia. Associated conditions encompass a broad spectrum of developmental abnormalities. Dandy-Walker malformation frequently coexists, reflecting shared disruption of midline development during critical embryological periods. Holoprosencephaly commonly includes callosal agenesis as part of prosencephalic cleavage abnormalities. Neuronal migration disorders including heterotopia, polymicrogyria, microcephaly, and abnormal sulcation patterns often accompany the malformation. Metabolic disorders and various chromosomal syndromes also demonstrate significant associations. Clinical manifestations vary dramatically based on associated anomalies. Isolated agenesis may remain completely asymptomatic throughout life, discovered only incidentally during neuroimaging performed for unrelated indications. However, even isolated cases can present with subtle learning disabilities affecting specific cognitive domains. Neuropsychological studies demonstrate impairments in abstract reasoning, problem-solving, and category fluency. Higher-level language difficulties appear in syntax comprehension and linguistic pragmatics. Some patients develop seizures, while others exhibit interhemispheric transfer deficits affecting tasks requiring coordination between brain hemispheres. Prognosis depends fundamentally on the presence and severity of associated malformations, rather than the callosal abnormality itself. So Triadis and Macrocephaly systematic literature review revealed that up to 75% of patients with MRI confirmed isolated agenesis develop typically by early school age, while only 11% experience severe disability. However, associated microcephaly, epilepsy, cerebral palsy, and cerebral dysgenesis significantly worsen neurodevelopmental outcomes. These findings emphasize the critical importance of comprehensive evaluation, including detailed neuroimaging, genetic testing, and multidisciplinary assessments to identify associated conditions that determine long-term prognosis and guide intervention strategies. Dandy-Walker malformation represents one of the most significant posterior fossa malformations encountered in neonatal practice, characterized by a classic triad that fundamentally alters cerebellar and brainstem anatomy. Understanding these anatomic features enables accurate diagnosis and appropriate management planning. The classic triad consists of partial or complete cerebellar vermian agenesis, which disrupts normal cerebellar development and function. Cystic dilation of the fourth ventricle, creating a characteristic retrocerebellar cyst that communicates with the ventricular system, and enlargement of the posterior fossa with upward displacement of critical structures. This enlargement forces upward displacement of the tentorium, torcula, and transverse sinuses, creating the pathognomonic imaging appearance that distinguishes Dandy-Walker malformation from other posterior fossa anomalies. Additional anatomic findings include upward displacement of these key posterior fossa structures, which fundamentally alters normal anatomic relationships. The pons may appear hypoplastic due to the interconnected nature of brainstem structures, contributing to the overall malformation complex. Occipital cranial prominence develops externally as a result of posterior fossa enlargement, creating the characteristic head shape associated with this condition. Hydrocephalus complicates 75% of Dandy Walker cases and represents the most clinically significant associated feature. This high prevalence reflects the complex CSF dynamics altered by the malformation, often requiring immediate neurosurgical intervention in the neonatal period. The incidence varies substantially in the literature, with estimates ranging from 1 in 5,000 to much lower rates, likely reflecting diagnostic criteria variations and improved prenatal detection. The malformation associates with multiple syndromes, including Walker-Warburg syndrome and Meckel syndrome, as well as chromosomal abnormalities, including trisomies 9, 13, and 18. The low recurrence risk of 1% to 3% suggests most cases result from de novo pathogenic variants, environmental insults, or vascular and multifactorial causes, making genetic counseling an important component of family support. Neonatal presentation of Dandy Walker malformation varies significantly based on the presence and severity of associated hydrocephalus and additional anomalies. Early recognition of characteristic features enables prompt intervention and improved outcomes through coordinated multidisciplinary care. Macrocephaly represents the most common presenting sign when hydrocephalus accompanies the malformation, occurring in approximately 75% of cases. The progressive nature of ventricular enlargement means head circumference may be normal at birth, but rapidly accelerate during the neonatal period, emphasizing the importance of serial measurements. The high-riding external occipital protuberance creates a characteristic external appearance that experienced clinicians can recognize on physical examination, representing the underlying posterior fossa enlargement and upward displacement of anatomic structures. Associated craniofacial malformations frequently accompany Dandy Walker malformation, reflecting the complex developmental disruption occurring during the 7th to 10th gestational weeks. These may include occipital encephaloceles or meningoceles, cleft lip and palate abnormalities, and other facial dysmorphisms that require specialized surgical expertise. The scope of associated anomalies proves remarkable, with approximately 50% of patients presenting with major congenital anomalies affecting multiple organ systems. Neurologic anomalies include microcephaly in some cases, agenesis of the corpus callosum, disrupting interhemispheric communication, and polymicrogyria affecting cortical organization. Ophthalmologic findings may include anophthalmia, while craniofacial abnormalities can involve craniosynostosis requiring surgical intervention. Cardiac involvement frequently includes complex congenital heart disease, necessitating cardiothoracic surgical evaluation and management. Magnetic resonance imaging provides the definitive diagnostic modality, clearly demonstrating the characteristic posterior fossa changes, including cerebellar Vermean hypoplasia, fourth ventricular cystic dilation, and posterior fossa enlargement with upward displacement of the tentorium and torcula. MRI proves superior to ultrasonography for precise anatomic definition and surgical planning, while also identifying associated brain malformations that impact prognosis and management decisions. Management of Dandy Walker malformation requires comprehensive multidisciplinary coordination, addressing both the primary malformation and associated anomalies that significantly impact long-term outcomes. Understanding prognostic factors enables realistic family counseling and optimal care planning. Ventriculoperitoneal shunt placement represents the cornerstone of management for the majority of patients, given the 75% incidence of hydrocephalus requiring surgical intervention. Early recognition and treatment of progressive hydrocephalus prevents further neurologic deterioration and optimizes developmental potential. The decision regarding shunt timing must balance risks of progressive ventricular enlargement against surgical risks in critically ill neonates with multiple anomalies. Surgical correction of associated malformations often requires staged approaches involving multiple subspecialties. Craniofacial reconstruction may be necessary for cleft lip and palate abnormalities, while complex congenital heart disease frequently requires cardiothoracic surgical intervention. Ophthalmologic abnormalities like anophthalmia may benefit from reconstructive procedures, and craniosynostosis requires specialized neurosurgical expertise. The complexity of these interventions necessitates careful prioritization and timing to optimize outcomes while minimizing perioperative risks. Multidisciplinary care coordination proves essential given the diverse organ system involvement. Teams typically include neonatal intensive care specialists, pediatric neurosurgeons, cardiothoracic surgeons, craniofacial specialists, ophthalmologists, and genetic counselors. Early intervention services become crucial for addressing developmental delays and optimizing neurologic function throughout childhood. Several factors fundamentally influence outcome prediction and family counseling. The presence of other brain malformations significantly worsens prognosis, with associated cortical dysplasias, corpus callosum agenesis, and migration disorders predicting poorer neurodevelopmental outcomes. Associated genetic conditions, particularly chromosomal abnormalities like trisomies, carry grave prognoses with limited survival expectations. The severity of hydrocephalus impacts both immediate management complexity and long-term neurologic function. Isolated Dandy-Walker malformation without associated anomalies offers the most favorable prognosis, with some patients achieving near normal development when hydrocephalus is promptly treated. However, cases with multiple anomalies carry guarded prognoses requiring realistic counseling about developmental expectations and quality of life considerations. Early intervention remains crucial regardless of prognosis, as optimal management can maximize developmental potential and improve quality of life for affected children and their families. Chiari eye malformation represents cerebellar tonsillar ectopia greater than 5 to 10 millimeters into the spinal canal, creating compression of the tonsils and restricted cerebrospinal fluid flow. This measurement threshold becomes clinically significant only when accompanied by symptoms, since similar degrees of herniation can occur asymptomatically in otherwise normal individuals. The malformation demonstrates important anatomic distinctions from Chiari 2. The posterior fossa maintains normal size in Chiari 1, contrasting sharply with the characteristically small posterior fossa seen in Chiari 2 malformation. This difference reflects distinct embryological origins and pathophysiologic mechanisms. Chiari may be either congenital, resulting from developmental abnormalities during posterior fossa formation, or acquired secondary to conditions that alter intracranial pressure dynamics or cerebrospinal fluid flow patterns. Syringomyelia represents the most clinically significant associated condition, occurring when disrupted cerebrospinal fluid flow creates cavitation within the spinal cord substance. This complication can produce progressive neurological deterioration, affecting both motor and sensory function, particularly impacting pain and temperature sensation in a classic cape-like distribution. Scoliosis frequently accompanies syringomyelia, reflecting the complex relationship between spinal cord dysfunction and skeletal development. Hydrocephalus occurs less commonly than in Chiari 2 malformation, but remains an important consideration requiring ongoing surveillance. Clinical presentation typically includes headache, particularly occipital headaches that worsen with Valsalva maneuvers or increased intracranial pressure. Lower cranial nerve dysfunction manifests as swallowing difficulties, vocal cord abnormalities, or sleep-disordered breathing. Cerebellar symptoms may include ataxia, coordination difficulties, or tremor, while brainstem involvement can produce nystagmus, vertigo, or autonomic dysfunction. The condition rarely presents during the neonatal period, more commonly becoming apparent during childhood or adolescence when symptoms develop or progress. This timing contrasts significantly with Chiari 2 malformation, which typically manifests early due to its universal association with open neural tube defects and resulting complications. Early recognition remains important because timely intervention can prevent progressive neurological deterioration and optimize long-term outcomes through appropriate surgical decompression when indicated. Chiari 2 malformation involves displacement of the cerebellar vermis, medulla, and fourth ventricle into the cervical spinal canal, creating a complex constellation of anatomic abnormalities that fundamentally alter normal posterior fossa architecture and cerebrospinal fluid dynamics. This malformation occurs almost exclusively in association with open neural tube defects, particularly myelomeningocele, representing a nearly universal relationship that reflects shared embryological disruption during primary neurulation between gestational weeks 3 to 4. The anatomical features create a pathognomonic imaging appearance that enables definitive diagnosis. The small posterior fossa with low-lying tentorium results from abnormal hindbrain development, forcing cerebellar and brainstem structures into inadequate space. The beaked tectum represents a characteristic deformity where the tectal plate adopts a pointed, beak-like configuration, serving as a highly specific diagnostic finding that distinguishes Chiari 2 from other posterior fossa malformations. The elongated fourth ventricle extends abnormally into the cervical spinal canal, disrupting normal cerebrospinal fluid circulation patterns and contributing to the complex hydrocephalus that characteristically accompanies this condition. Kinking of the medulla occurs as the brainstem herniates through the foramen magnum, creating potential compression that can produce life-threatening respiratory and cardiovascular complications. Supratentorial ventriculomegaly develops as a consequence of obstructive hydrocephalus caused by disrupted cerebrospinal fluid flow dynamics. The combination of posterior fossa crowding, abnormal fourth ventricular anatomy, and altered cerebrospinal fluid circulation creates a complex pathophysiology that typically requires multiple interventions, including both myelomeningocele closure and ventriculoperitoneal shunt placement. The universal association with open neural tube defects reflects the shared developmental timing and mechanisms. During primary neurulation, the same processes that lead to failure of neural tube closure in the spinal region also disrupt normal posterior fossa development, creating the characteristic constellation of abnormalities. This relationship means that every infant born with myelomeningocele requires careful evaluation for Chiari 2, malformation, and its associated complications, as the presence and severity of brainstem compression directly impacts both immediate management decisions and long-term prognosis. Chiari 2 malformation presents unique clinical challenges that directly reflect the complex pathophysiology of brainstem compression and altered cerebrospinal fluid dynamics. The initial presentation often appears deceptively benign, with head circumference that may be normal or even small at birth due to cerebrospinal fluid decompression into the myelomeningocele sac. This phenomenon creates a false sense of security that can mask the underlying severity of the malformation. The critical transition occurs after myelomeningocele closure when the previously available cerebrospinal fluid decompression pathway becomes eliminated. Rapid head growth frequently follows surgical closure as hydrocephalus develops or worsens, requiring immediate recognition and intervention. This timing makes serial head circumference measurements essential during the perioperative period, as failure to identify progressive ventriculomegaly can lead to catastrophic complications. Brainstem dysfunction represents the most serious complication category, with apnea constituting the most immediately life-threatening manifestation. The compressed and kinked medulla cannot maintain normal respiratory drive, leading to central apnea episodes that can prove fatal without prompt recognition and intervention. Stridor develops from vocal cord paralysis, caused by dysfunction of the recurrent laryngeal nerve, creating upper airway obstruction that compounds respiratory difficulties. Dysphagia and poor gag reflex result from cranial nerve dysfunction affecting swallowing coordination and airway protection mechanisms. These deficits significantly increase aspiration risk and feeding difficulties, often requiring specialized feeding approaches or gastrostomy tube placement. Nystagmus reflects vestibular or cerebellar dysfunction associated with the malformation, contributing to visual and balance difficulties. The clinical constellation carrying the highest mortality risk includes the simultaneous presence of stridor, apnea, cyanosis, and dysphagia. This combination indicates severe brainstem compression, requiring urgent neurosurgical evaluation for possible posterior fossa decompression. The surgical decision-making process must weigh the risks of intervention against the natural history of progressive brainstem dysfunction, with timing being critical for optimal outcomes. Early recognition of this symptom complex enables prompt intervention that can be life-saving, while delayed recognition often results in irreversible neurological deterioration or death. Chiari 2 malformation occurs within a complex of associated conditions that collectively determine clinical presentation, management strategies, and long-term outcomes. Hydrocephalus presents in nearly all cases associated with lumbar myelomeningocele, reflecting the disrupted cerebrospinal fluid dynamics caused by posterior fossa crowding and altered fourth ventricular anatomy. This high prevalence necessitates immediate neurosurgical evaluation and typically requires ventriculoperitoneal shunt placement, either simultaneously with or shortly after myelomeningocele closure. Supratentorial anomalies demonstrate the widespread impact of the embryological disruption affecting multiple brain regions. Partial agenesis of the corpus callosum occurs frequently, reflecting shared developmental timing between callosal formation and neural tube closure. The enlarged massa intermedia represents abnormal thalamic development, while stenogyria describes the characteristic pattern of narrow gyri that develops secondary to altered cortical organization. These findings collectively contribute to the neurocognitive difficulties commonly observed in affected children. Spinal abnormalities represent an invariable component, since Chiari 2 malformation occurs almost exclusively with myelomeningocele. The relationship proves so consistent that the absence of neural tube defects should prompt reconsideration of the diagnosis. Syringomyelia can develop as a secondary complication, creating progressive spinal cord dysfunction that may manifest years after initial surgical interventions. Tethered cord syndrome frequently coexists, requiring ongoing surveillance and potential additional surgical procedures to prevent progressive neurological deterioration. Cranial lacunia, also known as Lückenschädel skull, creates the characteristic beaten copper appearance on skull radiographs due to abnormal bone development in the setting of altered intracranial pressure dynamics. While often present at birth, this finding typically resolves after successful treatment of hydrocephalus, serving as an indicator of treatment effectiveness. The beaking of the tectum represents one of the most pathognomonic findings, visible on sagittal magnetic resonance imaging as a characteristic pointed deformity of the tectal plate. This finding proves so specific for Chiari 2 malformation that its presence strongly supports the diagnosis, even when other features appear subtle. The comprehensive nature of these associated conditions underscores why Chiari 2 malformation requires multidisciplinary management involving neurosurgery, orthopedics, urology, and developmental specialists. Each associated condition contributes to the overall clinical picture and influences both immediate surgical decision-making and long-term care planning throughout childhood and beyond. Craniosynostosis represents premature fusion of one or more cranial sutures, fundamentally disrupting normal skull growth patterns and creating characteristic head shape abnormalities. Think of normal sutures as expansion joints that allow the skull to grow as the rapidly expanding brain demands more space. When these sutures fuse prematurely, the skull loses its ability to expand in the direction perpendicular to that suture, forcing compensatory growth elsewhere. The incidence of increased intracranial pressure ranges from 4.5% to 44% in untreated cases, making recognition and management crucial for preventing neurological complications. This wide range reflects differences in study methodologies and suture involvement patterns, but the risk remains significant enough to warrant intervention in most cases. The classification system divides Craniosynostosis into two fundamental categories based on associated features and genetic patterns. Non-syndromic craniosynostosis accounts for 85% of cases and typically involves single suture fusion with normal development otherwise. These cases usually result from isolated developmental anomalies without broader implications for other organ systems. Syndromic craniosynostosis represents 15% of cases, but carries far greater complexity, involving multiple suture fusions accompanied by characteristic facial, limb, and systemic features. These cases often result from specific genetic mutations, particularly in fibroblast growth factor receptor genes, creating recognizable clinical syndromes with predictable patterns of involvement. The pathophysiology follows a predictable pattern based on Virchow's law. Failure of perpendicular growth relative to the fused suture creates restriction in one direction, while compensatory growth occurs at non-fused sutures. This mechanism explains why sagittal synostosis produces a long, narrow head, Scaphocephaly, while bilateral coronal synostosis creates a short, wide head, brachycephaly. Understanding this principle allows clinicians to predict which suture has fused based on the resulting head shape, making clinical recognition straightforward in most cases. The molecular basis involves normally functioning dural signals that promote patent sutures until brain growth completion. In Craniosynostosis, these signals become altered, leading to premature fusion and the characteristic compensatory growth patterns that create each syndrome's distinctive appearance. Each suture fusion creates a distinctive head shape that reflects the underlying pathophysiology, making clinical recognition straightforward when you understand the growth restriction patterns. Let me walk through the most common types, starting with the most frequent and building toward the more complex presentations. Sagittal synostosis represents the most common form of non-syndromic craniosynostosis, occurring in approximately 1 in 1,000 live births with a striking 4-to-1 male predominance. The fused sagittal suture prevents lateral skull expansion, forcing growth in the anterior-posterior direction to create scaphocephaly, literally meaning boat-shaped head. Picture a canoe viewed from above, long, narrow, and pointed at both ends. The characteristic features include narrow biparietal diameter, compensatory frontal bossing as growth redirects forward, temporal hollowing from restricted lateral expansion, and prominent occipital protuberance as posterior growth compensates for lateral restriction. Metopic synostosis produces trigonocephaly, creating perhaps the most dramatic appearance with its triangular forehead and prominent midline keel. Think of this as the skull trying to grow laterally, but being blocked by the fused metopic suture, creating a distinctive triangular configuration when viewed from above. The accompanying hypotelorism, closely spaced eyes, and temporal hollowing reflect the restricted interior skull base growth that accompanies metopic fusion. Coronal synostosis presents two distinct patterns depending on whether one or both sutures are involved. Unilateral coronal synostosis produces plagiocephaly, literally meaning oblique head, with characteristic flattening of the ipsilateral forehead and compensatory bossing of the contralateral side. The affected orbit appears shallow with upward and backward displacement, creating the harlequin eye deformity visible on imaging. Bilateral coronal synostosis creates brachycephaly, a short head that appears wide when viewed from above due to anterior-posterior growth restriction. The skull compensates by growing upward and laterally, sometimes producing pterocephaly or towering head when vertical growth becomes excessive. This pattern requires careful evaluation for associated syndromic features since bilateral involvement often indicates underlying genetic syndromes. Physical examination provides the foundation for craniosynostosis diagnosis, making careful clinical assessment more valuable than any imaging study. The key is understanding what to feel for and how to interpret the findings in context of the overall head shape pattern. Start by palpating along each suture line, feeling for the characteristic ridge that develops along fused sutures. In normal neonates, sutures remain mobile with gentle pressure, but fused sutures feel rigid and often raised. The loss of suture mobility, combined with the characteristic head shape, provides definitive clinical diagnosis in most cases. This hands-on approach proves more reliable than imaging for initial recognition. The characteristic head shapes follow predictable patterns that make clinical diagnosis straightforward once you understand the underlying growth mechanics. View the head from multiple angles, above, behind, and from each side, to fully appreciate the three-dimensional deformity. The shape abnormalities reflect the underlying suture involvement and help guide both diagnosis and surgical planning. Imaging confirmation uses plain skull radiographs as the initial study, demonstrating sclerosis along all or part of the fused suture. The sclerotic changes reflect the bone fusion process and provide objective confirmation of clinical findings. CT scanning increases diagnostic sensitivity, particularly in older children where suture mobility becomes more difficult to assess and proves essential for operative planning when reconstruction becomes necessary. The critical differential diagnosis involves distinguishing true craniosynostosis from positional plagiocephaly, which represents the most common cause of abnormal head shape in infants. Here's the key distinguishing feature that every clinician must master: ear position. In positional plagiocephaly, the ear displaces forward on the flattened side because the entire skull shifts in that direction. In lambdoid synostosis, the ear displaces posteriorly because growth restriction occurs behind the ear position. Think of it this way. Positional flattening pushes everything forward, while suture fusion restricts growth, pulling structures backward. This single examination finding can prevent unnecessary imaging and surgical consultations while ensuring appropriate referrals when true synostosis exists. Master this distinction, and you'll correctly diagnose the vast majority of cases based on clinical examination alone. Syndromic craniosynostosis presents complex multisystem conditions that require systematic recognition of characteristic patterns. These syndromes often result from mutations in fibroblast growth factor receptor genes, creating predictable constellations of findings that extend far beyond skull abnormalities. Let me break down the 3 most important syndromes you'll encounter, focusing on the distinguishing features that enable accurate diagnosis. Apert syndrome affects up to 1 in 65,000 births and creates perhaps the most recognizable presentation. The hallmark feature is symmetric syndactyly of hands and feet, complete fusion of fingers and toes that's immediately apparent at birth. Think of this as mitten hands and sock feet, where individual digits cannot be distinguished. The cranial features include brachypterocephaly with a flattened occiput, most commonly involving bilateral coronal synostosis, with a widely open anterior fontanelle and metopic suture. Maxillary hypoplasia creates the characteristic mid-face retrusion, while cognitive delays occur in the majority of cases. Crouzon syndrome presents similar cranial features to Apert syndrome, but with a crucial distinction: normal limbs. The craniofacial abnormalities typically aren't present at birth, but develop over time as synostosis progresses. Bilateral coronal involvement creates brachycephaly, while exophthalmos, prominent eyes, and maxillary hypoplasia produce the characteristic facial appearance. Unlike Apert syndrome, cognitive development usually remains normal, making this distinction clinically important for family counseling. Pfeiffer syndrome demonstrates the distinctive feature of broad thumbs and great toes. Think of these as boxer's thumbs that appear disproportionately wide compared to normal digits. The cranial features include brachypterocephaly and maxillary hypoplasia, similar to other syndromic forms. Pfeiffer syndrome has 3 distinct types, with type 3 representing the most severe form, presenting with cloverleaf skull deformity. This creates a characteristic 3-lobed appearance when viewed from above due to multiple suture involvement and compensatory growth patterns. The key to syndromic recognition lies in looking beyond the skull to identify the characteristic limb and facial features that distinguish each condition. While the cranial abnormalities may appear similar, the associated features provide definitive diagnostic clues that guide genetic counseling, surgical planning, and long-term management strategies. Understanding the broader spectrum of syndromic craniosynostosis helps recognize less common but equally important conditions that require specific management approaches. These additional syndromes demonstrate the genetic diversity underlying craniosynostosis while sharing common clinical challenges that affect multiple organ systems. Muenke syndrome represents the most common syndromic craniosynostosis, affecting as many as 1 in 30,000 live births, making it more prevalent than many clinicians realize. The FGR3 gene mutation creates an autosomal dominant inheritance pattern with variable expression that makes recognition challenging. Most commonly, bilateral coronal synostosis occurs, though the spectrum of premature suture closure ranges from single suture involvement to pansynostosis. The variability in presentation explains why some family members appear minimally affected, while others require extensive surgical intervention. A distinguishing feature of Muenke syndrome involves sensorineural hearing loss rather than the conductive hearing loss typical of other syndromic craniosynostoses. This difference reflects the broader impact of FGR3 mutations on inner ear development. Genetic testing provides definitive diagnosis and enables appropriate family screening, particularly important given the autosomal dominant inheritance pattern. Sethry-Chotson syndrome presents with brachycephaly and characteristic facial features, including low-lying hairlines that create an unusual forehead appearance, ptosis that affects eyelid position, and hypertelorism with widely spaced eyes. Variable limb anomalies may occur, but aren't as consistently present as in other syndromes. The facial features often prove more diagnostic than the cranial abnormalities in establishing the correct diagnosis. Common associations across all syndromic craniosynostoses include several predictable complications that require systematic monitoring. Hearing loss affects the majority of patients, though the type varies by syndrome. Conductive loss predominates in most conditions due to middle ear abnormalities, while sensorineural loss characterizes Muenke syndrome. Respiratory difficulties, particularly obstructive sleep apnea, occur frequently due to midface hypoplasia that narrows the upper airway. Cognitive deficits show variable expression both between and within syndromes, emphasizing the importance of individualized assessment rather than syndrome-based assumptions about intellectual potential. These shared complications underscore why syndromic craniosynostosis requires multidisciplinary management involving specialists across multiple domains rather than purely surgical intervention. Successful craniosynostosis management requires understanding the critical timing window when intervention proves most effective, combined with comprehensive multidisciplinary coordination that addresses both immediate surgical needs and long-term developmental concerns. Surgical timing centers on the first year of life, with procedures ideally performed before 6 months of age when possible. This timing reflects a fundamental principle. The brain triples in weight during the first year, providing tremendous growth potential that can guide skull remodeling toward normal shape. Think of early surgery as removing the roadblock to normal growth rather than simply reshaping static bone. After 6 months, the brain's rapid expansion begins to slow, reducing the natural forces available to help reshape the reconstructed skull. The rationale for early intervention extends beyond cosmetic concerns to prevent progressive complications. Untreated craniosynostosis can lead to increased intracranial pressure, developmental delays, and progressive facial deformities. Early surgical intervention harnesses the brain's natural growth forces to achieve optimal outcomes while preventing these secondary complications. Multiple surgical approaches exist, ranging from minimally invasive endoscopic procedures in early infancy to traditional cranial vault reconstruction techniques. Endoscopic approaches work best in very young infants when sutures have recently fused and extensive remodeling isn't yet necessary. Traditional reconstruction becomes necessary when more extensive reshaping is required or when diagnosis occurs later in infancy. Orbital bar advancement represents a specialized technique used when frontal or coronal suture involvement affects the eye sockets, correcting both functional and cosmetic concerns. The choice between techniques depends on patient age, suture involvement pattern, and severity of deformity. Multidisciplinary team involvement proves essential given the complex needs these patients present. Neurosurgery and plastic surgery provide the primary surgical expertise, while ophthalmology monitors visual development and orbital complications. Orthodontics addresses dental and jaw alignment issues, particularly important in syndromic cases with maxillary hypoplasia. Audiology manages the frequent hearing complications, while genetics provides counseling and screening services, especially crucial for syndromic forms with hereditary implications. Long-term monitoring focuses on intracranial pressure surveillance, developmental assessment, and management of associated complications. The goal extends beyond successful surgery to optimal neurodevelopmental outcomes and quality of life throughout childhood and beyond. Encephaloceles represent cranial skull defects where brain tissue protrudes through skull openings, occurring before 26 days of gestation as post-neurulation disorders. The geographic distribution shows striking patterns. Occipital encephaloceles predominate in Western populations at 80%, while frontal encephaloceles are more prevalent in Southeast Asia, reflecting ethnic genetic factors that influence lesion location. The severity spectrum ranges from cranium bifidum with skull defect only to cranial meningoceles containing meningeal tissue without neural elements to true encephaloceles that include brain tissue. This classification directly impacts surgical planning and prognosis. Approximately 50% of infants present with associated major congenital anomalies, including microcephaly, cleft lip or palate, complex congenital heart disease, and other malformations. The genetic component is evident through increased risk in chromosomal disorders and recessive syndromes like Meckel and Joubert syndromes. making comprehensive evaluation essential for optimal management planning. Clinical presentation varies significantly by anatomical location. Occipital encephaloceles present as posterior skull defects with tissue protrusion that may contain substantial brain tissue and frequently associate with other CNS anomalies. These lesions can be quite large and are easily visible on examination. Anterior encephaloceles, including frontoethmoidal, nasal, and orbital locations, present unique diagnostic challenges. They may appear as intranasal masses, particularly when a broad nasal bridge and widely spaced eyes are present, key clinical indicators warranting immediate evaluation. The risk of recurrent meningitis becomes significant when CSF communication exists through these defects. Critical clinical signs include pulsatile masses that demonstrate the positive jugular compression test. Frontonasal encephaloceles pulse or bulge, with brief bilateral jugular vein compression, confirming communication with the subarachnoid space. CSF leakage presents an immediate infection risk requiring urgent intervention. Recognition of these signs enables rapid differentiation from nasal gliomas, dermoids, and teratomas that can occur in similar regions but lack CSF communication. CNS associations significantly impact surgical planning and prognosis. Hydrocephalus occurs in approximately 17% of anterior encephaloceles based on large series data, while posterior encephaloceles show higher rates. Additional frequent associations include agenesis of corpus callosum, polymicrogyria, heterotopias, and anomalous venous drainage patterns requiring detailed imaging evaluation. Chiari 3 malformation specifically occurs with lower occipital encephaloceles, combining skull-based defects with cerebellar and brainstem malformations. Beyond CNS involvement, systemic anomalies include microcephaly, cardiac defects, cleft lip/palate, and limb anomalies. Chromosomal syndromes such as Meckel, Joubert, Walker-Warburg, and trisomies 13 and 18 frequently present with encephaloceles. Complications requiring immediate attention include meningitis risk with CSF leak. Some children with anterior encephaloceles present with recurrent meningitis as the initial symptom. Seizures develop in many patients and can be medically intractable, though surgical resection may provide control. The complexity of associated anomalies necessitates multidisciplinary evaluation to optimize outcomes and provide accurate prognostic counseling. Emergency management prioritizes infection prevention through sterile dressing and trauma avoidance, with immediate neurosurgical consultation. MRI with magnetic resonance, angiography, and venography represents the imaging study of choice for surgical planning, providing detailed anatomy of neural tissue, vascular structures, and associated malformations. Surgical intervention timing depends on infection risk. Early treatment is imperative for lesions with external CSF communication. However, brain tissue exterior to the skull typically cannot be salvaged, making surgical goals focused on dural closure and cosmetic improvement rather than neural preservation. Large lesions or severe CNS anomalies may preclude intervention entirely. Prognosis varies dramatically by location and associated features. Mortality data shows striking differences. 29% overall mortality, with 45% for posterior defects versus 0% for anterior defects. Among survivors, neurologic deficits are severe in 33%, with anterior defects showing better outcomes. Mild deficits in 17% of anterior survivors versus 50% of posterior survivors. Developmental prognosis depends critically on the amount of neural tissue within the defect and associated brain anomalies, with favorable outcomes possible when brain anatomy remains normal. These clinical pearls represent high-yield concepts essential for NICU certification success. Hydrocephalus monitoring requires tracking head growth velocity, not just absolute size. Rapid changes indicate developing complications requiring intervention. Holoprosencephaly follows the principle that facial severity correlates directly with brain involvement and prognosis. The face truly predicts the brain. Microcephaly carries significant developmental implications, with 80% of severe cases resulting in developmental disabilities. Dandy Walker malformation develops hydrocephalus requiring intervention in 75% of cases, necessitating close monitoring. Chiari 2 malformation occurs universally with myelomeningocele, and brainstem dysfunction represents the most life-threatening complication. Craniosynostosis diagnosis relies on physical examination findings to distinguish true synostosis from positional changes. This clinical skill prevents unnecessary imaging and interventions. For Encephaloceles, early recognition prevents devastating meningitis complications, while comprehensive imaging proves crucial for surgical planning and prognostic counseling. Family counseling must emphasize honest prognosis with multidisciplinary support and quality of life focus. These conditions require longitudinal care with realistic outcome expectations while maintaining hope and supporting family adaptation to complex medical needs.